Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai. And today, someone with me who is mentor of mentors, teacher of teachers, Professor Farooq Afzal. He is pioneer of bariatric surgery in Pakistan and well-known bariatric surgeon as well as great teacher. And really, as I know him now at least 5-6 years, on regular basis, always he's trying his best to educate youngsters, always. And he's a great inspiration in Pakistan, especially for youngsters. As my viewers, you know, we have started this series of interviews with MGB, OAGB, then safe sleep gastrectomy, and now Rohan-Vai gastric bypass is going on, and Professor is one of them who is expert in Rohan-Vai gastric bypass. Sir, I will not take your time. Please, sir, over to you.
Thank you very much, Imran. I think, first of all, I need to congratulate you for organizing this GLR and doing a wonderful work in Pakistan and abroad. I think because of your efforts and your team efforts, laparoscopic surgery, and particularly the bariatric surgery and the other advanced laparoscopic surgery, has been advanced so much. And I'm so delighted that even at the district surgeons level, we are having a lot of new avenues, new young surgeons being inspired and doing a lot of wonderful work. And I think credit goes to you and your team, and just keep it up. I am really very much impressed what the progress has been made for the last 5-6 years. And I'm very hopeful that the future of especially the minimal access surgery and advanced laparoscopic surgery and bariatric surgery is very, very bright, inshallah, in my country.
Sir, this all is due to your guidance. There is no doubt, due to your mentorness and all of these, your guidance and your support. Definite. You are always, I always talk with my youngsters, you are always supporting, you are always encouraging. Sir, we have divided this question, especially in 3 sessions. So we will talk about some pre-operative and patient selection. Then we will touch some technical points. And at the end, we will talk post-op, so results and care and what is your experience? So first of all, because personally, I know, but because we have international viewers and maybe because we are live on Facebook group Global Laparoscopy, so your brief introduction, your journey of bariatric surgery, and especially Rohan-Vai gastric bypass.
Yeah, so I did my fellowship in 1995 for Pakistan College of Physicians and Surgeons. And then I went to UK. I wanted to do a fellowship. And where I met J.R. Smith. J.R. Smith was basically at that time also the president of Royal College of Surgeons of Edinburgh. And we in Pakistan never knew about this bariatric surgery. Even we were not advanced. When I saw him first time operating on a big patient, and he was trying to do a VBG, the vertebral belt gastroplasty. And I was very much amazed, but because I didn't understand anything, because the idea was totally, how is he creating gastric restriction? Absolutely, I admit, I had no idea. But it fascinated me that, there is also a surgical way of correction of such obese patients. And then later on, I had an opportunity to go to Saudi Arabia after doing this FRCS. And I saw Saudi has got probably the second highest incidence of obesity. And I saw a huge, big patient being operated. And that time they used to do bands. And Professor Abdullah Dohan was one of my teachers over there. He was chairman department of surgery at the same time. And Professor Abdullah, and since I was a senior registrar to start with, so we learned a lot with him at least from 2003 to 2006. We were involved in this bariatric surgery. In later part of 2006, rather 2005, we invited Roberto Tacchino from Italy to teach us how to do gastric bypass. So Tacchino came in 2005 and he did, a series of cases, and that impressed me a lot. And I wanted to go to US. So I did my steps long before I was in house job. And I didn't manage to go to US. There are multiple reasons for that. But then based on my steps, I applied for a fellowship in United States. And I was lucky that I got fellowship with the group of Lee Swanstrom and Emma Patterson. And Emma was my program director at Portland, Oregon. And from there onwards, my journey started. So I completed my fellowship. And at that time, a fellowship requirement was you have to do a 60% bands and 40% gastric bypass. And they used to do the gastric bypass with a circus slapper, which I never did it afterwards because it was not applicable in my setup. So I came back to Pakistan 2007, October 2007 or early 2008. And for the first 6 months or a year, we were just trying to convince people that we need to establish something here. But there were no tables, there were no concept of long instruments. I would tell you that the first scope which was being bought in front of me was a 0-degree scope. And I asked my teacher at that time that this is now a modern world. If you want to go to advanced laparoscopic surgery, you have to buy a 30-degree laparoscope. And at that time, right at that moment, we bought this 30-degree laparoscope, and that changed the horizon. So we started first of all in Services Hospital. At that time, Professor Faisal Masood was, may God bless his soul, he was very instrumental in giving us a research grant of about 1 crore rupees. And from that 1 crore rupees, we bought instruments, we bought staplers, we bought table. And this is how we started from Services Hospital and at the same time, privately from National Hospital. And the journey started initially slowly. And then it, Alhamdulillah, I'm so glad that it has now flourished in every corner of Pakistan.
Sir, definite. So this all result, and now we can see the beauty of the surgeon all over the Pakistan till MIS in district and SC level. This is all of this credits goes to you, sir. You, your team, your pioneer, no doubt. Sir, already you have highlighted about the setup. So because most of our viewers are also youngsters from Central Asian states, from Middle East, and also from South Asia, I am interested to hear from your side minimum setup for bariatric surgery.
Yeah, so first of all, you need to understand that it is a little bit different from the standard laparoscopic surgery we do. So standard laparoscopy, we do a different sort of instruments like maybe 33 centimeter or maximum 37 centimeter. But you all know that the bariatric surgery, you need long instruments, at least 43 centimeter or 45. So initially, you must identify a good instruments, long length instruments, long length telescope, and a good laparoscope. I mean, the tower and everything should be, and now we have HD and 3D and stuff like that. I think we should invest in good optics, good energy sources. We have now multiple choices of energy sources. And once you selected your instruments, then is your team. Now, team, there are 3 teams. One is a surgeon team. You need to have a surgeon who's as good as you. So there is an assistant, first assistant who should be as good as you. Then maybe another second or third assistant. So that is a surgical team. The second most important team is the anesthesia team. I think bariatric anesthesia is totally different from other anesthesia. And for that reason, you have to have anesthetist who should be your regular anesthetist. He is the one who should not be doing other cases. He should be doing anesthesia with you, because understanding anesthesia of a bariatric patient is totally different. So that I would suggest that you should have a good anesthesia team. The third team is your nursing and paramedics. Your nurses are very, I would probably believe that your nurses are more important than your first assistant, because they are going to make your job easy, right? So your nurses, the person who's taking, the paramedics who's taking care of your instruments and their sterilization, these are the importance. So what I will believe is that keep a same team for your initial cases. Otherwise, if you start with a different team, you will be in trouble. Now, then is the logistics. In the logistics, I think the most important thing is the OR, and in the OR, the table is most important. I think when I started in Doctor's Hospital, the first question our Doctor's Hospital was that we cannot provide you with the table. You have to invest in table as well. So I invested in table, I invested in the tower, right? Everything initially you have to invest in it. So that is a huge thing. So that's the reason people find it initially difficult to start with. But if you keep on these recommendations, like picking up the good instruments, the good laparoscope tower, then the team which I mentioned, the three teams, the surgeons team, the nursing team, and the nurses and the paramedics, anesthesia team, they are important. And then the tables. So if these are the thing, then you start thinking of obviously starting a program in a new setup.
Sir, so much thanks. And hopefully for my youngsters, so completely Professor explained, no need to rush to go for bariatric surgery. These are the basic points. Other than, so your training, your learning curve. So if you're going to start bariatric, please be careful. Sir, regarding rural gastric bypass, because in this session, we will talk about pre-op. So according to your experience, what is the relative and absolute contraindication of rural gastric bypass?
Well, relatively, I don't think so. There is an absolute contraindication, but most of these are relative contraindication. So I'll be like looking after a patient who is psychologically dependent, who is on alcohol, who's got a cirrhosis or a portal hypertension, or got a small bowel disease like Crohn's or inflammatory. These are the patients, or maybe previous surgeries done, there are a lot of adhesions in it. These are patients I'll be relatively very careful and probably would not be offering. Similarly, I would be a little bit cautious in doing it in high BMI, especially in a male patients. Yeah, these are also difficult patients. So some sort of stage procedure should be advised for such patients. Otherwise, this may be coagulopathy, which is a relative contraindication, heart failure. These are all relative contraindications for other surgeries. They are also applicable for gastric bypass. But I don't think there is an absolute contraindication to gastric bypass. There are all probably relative contraindications.
Sir, have you any concern for smokers?
Yeah, smokers, I do have a concern with smokers. Smokers have a lot of associated comorbidities, plus there are high chances of marginal ulcers. So what we do is we ask them to have a complete abstinence for at least 4 weeks. This is the minimum. And if they cannot do that, they have to be put on alternative strategies so that the smoking has to be stopped, because obviously it has a direct impact on not only lung complications, but later on the complications, especially in the form of marginal ulcers.
Yeah. So regarding age limitation, so if we see adolescents are older age, older than 65, so what is your protocol? Again, you will go, have any experience from my gastric bypass in such age?
So I have never done a bypass under the age of 30. I usually don't do a bypass under the age of 30. Yes, above the age of 30, we do gastric bypass. Relatively, most of my patients who have done bypass are in the age of their 40s and 50s. These are one, especially in the 4th and 5th decade, are the one which are most of my patients. There are people who think that the gastric bypass can be done in younger patients, and there are people who think that the gastric bypass can be done in extremes of ages. Well, absolutely, I do not deny with that. But what I believe is more comfortable doing such in this middle age group. From 30 to 60 is my age group, which I probably operate.
So regarding pre-op endoscopy and H. pylori eradication, what is your protocol?
Yeah, Imran, I think, they are set up in which, when I was in States, it was compulsory. There was a standard set because it was funded by insurance. So if you're not done these 1, 2, 3, 4, 5, 6 checklists, you would not be approved for the surgery. But in Pakistani setup, we are like handicapped by certain situations. We have to cut the corners, especially in cutting the corners of the cost, especially. And people are very much afraid. I don't know what is the psyche. People are very much afraid of putting a scope into their mouth. Maybe it's not done under general anesthesia, it's done under sedation, and they've seen people doing it. The memory of that procedure is absolutely very frightening for most of the people. So for that reason, I think people don't accept this gastric endoscopy, upper GI endoscopy before surgery. So most of our patients would not have it. Yes, when we suspect and we have to convince that patient that you definitely need this, that is the people they will do it. So in my practice, hardly 15% or maybe 10%.
It's good. So regarding post-menopause female patients, sometimes they are suffering with osteoporosis, and that is symptomatic osteoporosis. Are you evaluate these patients, and again you will go for any type of malabsorptive surgery in such a case?
Yeah, in osteoporosis, I think mostly when you are offering them malabsorption, there's a high risk of obviously later on problems, especially fractures and stuff like that. But I think if this is a good indication, if they offer, especially for metabolic reasons, they offer these gastric bypass operation. I will be careful in doing an MGB incised patient, but gastric bypass is relatively less malabsorptive as compared to MGB. So probably with good counseling and good follow-up, they can still undergo a gastric bypass, provided they are regular in their follow-up and they are looking after their deficiencies of calcium, vitamin D.
Excellent, sir. Sir, now we will touch some technical points. So definitely any surgeon, so this is the evolution of technique. And now about more than 1 decade, so I think 15, 16 years. So you are involved in gastric bypass after your fellowship program. So technically, so in this situation that you are practicing in Pakistan, you know your patients, your culture, definitely different than US, no doubt, dietary habits. So those steps that you see, so yes, it was better. I must do like this, the size of pouch, size of gastro, jejunostomy. We will talk further BP limb. So can you explain, highlight those points?
So let's go with the gastric pouch formation.
Yeah.
So gastric pouch formation, when I worked with Emma, and Emma used to at least use 4 staples. So we used to have a long but narrow pouch, right? So 4 pouch means that roughly 40 to 50 cc of gastric pouch, right?
Yeah.
So that was the initial. And the other advantage of longer pouch was that anastomosis was relatively easier when you have a longer pouch. She used to, we were trained in cutting the mesentery and then putting the proximal part up and distal part down and stuff like that, and used to do a circular stapler gastrojejunoscopy, right? Our standard lamb length of BP was, irrespective of whatever the patient was, 50. And if the BMI is more than 50, it was more than 120, so roughly about 150. But if the BMI is less than 50, it was 120. So throughout my training, we used to do this BP limb of 50 and elementary limb of Aru limb of only 120. And if the BMI is more than 50, it was 150. But later on, over the period of time, when I came to Pakistan, initially we started because there was no circular stapler at that time when I started. There was no circular stapler available, which was a size of 25, right? They were bigger, but the 25 size stapler was not available. So what we do is started with the linear ones, and the linear staplers we used. And gradually over the period of time, my pouch size is now I do with the 3 staplers. So it's roughly 1 stapler horizontal, 2 vertical wise. And that probably takes to 25 to 30 cc pouch. So we have a smaller pouch. But what I've done is over a period of time, the gastrojejunostomy size, instead of a smaller gastrojejunostomy size, now I have started doing a bigger gastrojejunostomy size. And one of the concern is that if you leave a small pouch and a smaller outlet, later on the gastric pouch gets dilated because there is an outflow obstruction effect, and it gradually dilates. And when it dilates, there are more incidents of marginal ulcer formation. So for that reason, now what my pouch has been modified into a still a smaller pouch, but with a wider gastrojej. So now I do about I think 3.5 centimeter gastrojej. That's one. The second thing is that now added, instead of like for a BMI, I'm increasing my rule limb to 120, 150. Now I've started increasing the BP limb. So instead of like 50, for a higher BMI, I might choose 75, even up to 100 in certain cases. So I kept my rule limb fixed, but my BP limb over a period of 10 years, now we started increasing the length. We know that increasing the BP limb has a more malabsorptive effect. So this is the change we have done.
Excellent.
Right.
Yeah, excellent, sir. So, but it was really interesting for me. Your RU limb is longer than BP limb initially. So 120, and that was the RU
Yeah,
was,
it
but
was like that.
yeah, if we see, so because the RU limb is also elementary limb and there is some absorption of carbs. So then you have started to increase BP limb, that is the pure male absorptive component.
Yeah, yeah. The initial reason why you see that this rule limit is 120 was they wanted that the reflux has to be prevented. The original idea was it has got nothing to do with the weight loss. Primarily, you leave a longer limb because you want to prevent the reflux. Whatever malabsorption has happened in the BP limb, and this limb is not that much concerned. But now we know that it has this BP limb has more relevance as compared to the rule limb.
Sir, another topic. So always we talk about the size of pouch, and when size of pouch is little bigger, there is more acid production and more chance of marginal ulcer. So you have decreased the size about 40%, 60%. You have decreased. So have you any not study? So your experience when the size of pouch was bigger, then little marginal ulcer was more and now less. Or no, there is no such a difference.
Now, we initially had marginal ulcers. Lately, in my patients for the last 3 years, I didn't find any marginal ulcers, but initial, yes, when we doing larger pouches and smaller anastomosis, yes, we had that large. Especially, I've seen more marginal ulcers with the circular staplers. So I've done few cases with the circular stapler, and then now I don't do anything with the circular stapler. I'm again back. So there are three switch: circular stapler to linear, then back to circular, and again now back to linear. So I think if you have a narrow anastomosis and using circular stapler, there are more chances of marginal stress. And obviously, smoking has to play a part.
Yeah.
And I was surprised because 10 to 15% of even my female patients are smokers, and they later on tell you that they are smokers. They do not disclose it before surgery.
So regarding hands-on anastomosis, so because definitely the big names, they also still they are doing this, and also they promote this one. So then there is less chance of marginal ulcer due to absorbable suture and or no. And when we use stapler, there is titanium and foreign body. So this is the concept. I don't uh, recognize this, but just the opinion I share. So what's your
Yeah,
experience?
so what we tried with the locking stitch, these locking sutures, we tried those hands in, and I think very practical one. But again, then it was a very short experience, and I believe that if you have to, I mean, take off our dependence from the staplers, these locking stitches are better, and even without locking stitch, you can do a hand sewn anastomosis. The only problem is the surgeons are like time short, and they probably do something quickly, and the staplers make these things easier and quicker for you.
Sure. So regarding hiatal hernia, so if patient is suffering with hiatal hernia and you have diagnosed before surgery, so are you repair or you do hiatoplasty and then you will go for one by gastric bypass?
Obviously, I would see how much is the patient symptomatic. Well, that is one reason. The other is the large hiatal hernia. There's a risk of paraesophageal hernia at the same time. So for larger hernia, like 3 to 4 centimeter, uh, our preference is to do a hiatoplasty because obviously then there is a risk of herniation. But less than that, doing a gastric bypass, I probably would not do any repair or anything. I would just leave them as such.
Yeah. So regarding this, because sometimes then there is hiatal hernia, we also repair hiatal hernia and this pouch is small size and sometimes migrate to so mediastinum. So are you agree to fix this pouch, gastropexy, that pouch, or no need to do this?
Well, I probably would not do it, although I do it in sleeve gastrectomy because I believe there are more chances of the sleeve migrating into the chest. So
Yeah.
I usually fix the sleeve with the left press, but not in this small pouch in the gastric bypass.
And there is no need to do this. So regarding, so one another thing in my opinion that is also nightmare also for the patient and as well as for the surgeon is internal hernia after one by gastric bypass. So are you routinely close these defects?
Yeah, this is a long debate. I'm an old-fashioned guy like Professor Abir Khan, and every time we want to do a scientific reasoning. So I understand the Swedish group 2016 they presented their data. This is the first scientific data proving, but still, if you go statistically, the numbers needed to treat because that is the basics of statistics. So if you have some intervention and the numbers needed to treat are less, so it will be convinced. Still, I have to repair more hernias to prevent one incidence of internal hernia. So the field is still open. I usually do not close this Peterson defect.
Have you experienced any internal hernia in your own patients?
No, not in my patient. One patient I suspected that he might have it because there was a recurrent attacks of it. But I tell you, even our own CT scan people are not good in picking up those internal hernias because when they're internal, sometimes there's internal hernia, then it got dislodged, and probably they are not able to pick it up. If you're suspected, probably the only thing is that you do a scope, and then probably you are unable to. So since these CT scans are not good enough to, they are good enough to tell you when there is probably incarceration or strangulation, but this rarely happens in internal hernia in gastric bypasses.
Yeah, sure. Sir, regarding, so because now we will talk little about post-op, and in my opinion, that is also most important one. So what is your routine post-op follow-up, especially endoscopic surveillance? I know in Pakistan already you have mentioned, but maybe some symptomatic patient need to do endoscopy. So what is your protocol?
So if my patient is having all the features suggesting that there's a possibility of a marginal ulcer or sometime narrowing in the first 6 weeks, right? I make sure that they get a scope in, right? Before the scope, they get this contrast study. I make sure that because sometimes there is a chance of narrowing at the gastro judge, and that is the time at 6 weeks. This is the time if you do dilatation, you can prevent first. So I insist, rather I will go and get it done for them. Now later on, after 1 year or 2 years, they still have some problems. But at that time, convincing somebody to get a gastroscopy done is far difficult. They get convinced to do this upper GI studies, but they would not be convinced to get this gastroscopy done for them. So that is again the problem which I showed you, the poor compliance of the patient and the reluctance to do this gastroscopy. But yes, initially when you're suspecting something can happen in the first 6 weeks, yes, patients are also because they are afraid that something goes wrong with the patient, with the operation. And when you tell them that there are chances that you will have a lifelong problem, so they are convinced. But later on, surveillance with the endoscopy is having a less compliance within our setup. They are ready to drink a contrast, but not to put a scope in.
Yeah, definite. Yeah, I know, sir. Sir, regarding this marginal ulcer, again, this is also an issue after one by gastric bypass. Which percentage of your patient are suffering with marginal ulcer?
Yeah, I believe that 2 of my patients, they did bad on this. And I think we put them on chronic, this PPIs. They respond when they leave PPIs, they do not. So we did a scope in, there was an ulcer. We give them IV therapy as well as oral therapy for longer. It resolves, it comes back. But to my knowledge, they did not agree to any revision of an atmosphere or any other surgical intervention, right? And unfortunately enough, I didn't see any bleeding or any perforation to the marginal ulcers. So I was lucky in that sense. We have other problems, but not related to the marginal ulcers.
It's good. And also regarding, because there were limited patients, only 2 patients, they were smoker or no, this was not important because only for
No, one is a female, the other is a male. So I don't know, male may be smoker, but he denies that. The female is not a smoker.
yeah, because I have asked sir regarding H. pylori eradication. Is your protocol to eradicate H. pylori before going to do surgery?
No, we do not. But if there is a endoscopic evidence, yes. So on the contrary, sleep patients, we used to send these specimens, and the report used to say that's H. pylori positive. So sleep patients, this is by routine. We used to send, and we used to eradicate them, but not in this population of gastric bypass patients.
Sir, after Rowan by gastric bypass, how long time you suggest your patient to use PPI and which dose you prefer?
So I usually give them this 40 milligram of second generation PPI, usually an Nexam or any other, and I give them for 3 months with this Alsanic for at least 1 to 2 months. This is my standard protocol.
Yeah,
And I also give also for initial 3 months for prevention of gallstones.
that is also you use Orsodil or this such a tablets, and it is effective.
Yeah, it is effective because those patients in which we are given, at least they do not develop it, right? Not all of them, but you can still say, because people are very knowledgeable these days.
Yeah. Sir, please unmute yourself. Unmute yourself, sir.
So people are very knowledgeable these days. They have read the books, they have talked to their other groups, and they will say, if the other doctor is saying this, why are you not saying this? So for that reason, they know what other doctors are doing, because the patients, they have a communication with each other. And for that reason, they will come and say, why you didn't prescribe URSO to us? I know that URSO is effective probably in maybe 30 to 50% people, but not in every patient. But we do give them.
Yeah, regarding sir, micronutrient deficiency, definite when we do any type of hypoabsorptive surgery, and but are you using definite supplements, and how long time you prescribe for your patient to use supplements?
Well, I'll ask them to do it for lifelong, especially 3 to 4 months. Every 3 to 4 months, they're supposed to get calcium, vitamin D, iron, B12 levels every 4 months, and they need to have supplements. So calcium, vitamin D, B12, these all supplements have to be taken by them. And this, I have to tell them that this is for lifelong. They cannot get away with it.
Sir, in your patients,
Micronutrients, we usually do not screen for micronutrients unless there is some problems about it. And surprisingly, neither I found it, nor I have seen in my Pakistani literature, nor in my Pakistani group, that we have gone for micronutrient deficiencies. People talk about copper and manganese and stuff like that, but it's not my experience.
Sir, one of the issue, especially in female, is hair fall after any type of weight loss. So how you deal with these patients?
These are very difficult patients. I tell them, I reassure them that initially it would happen and later on it would stabilize. Take a high protein, maybe Cerbex Z, maybe zinc, maybe some shampoos. Consult your dermatologist. It will happen. It will happen in most of the females, but it will settle down after a few months. And usually they get satisfied. And if you have forewarned them before surgery, they are mentally ready for that. They are only in trouble when you have not told them, and then come, doctor, why have you not told us what was wrong with our hairs?
Yeah, sure, sir. Sir, regarding sagging, that is also another issue, and especially in female patients. Personally, also I face routinely in Dubai. Also, so how we prepare the patient so less sagging, I don't know.
Yeah, so sagging is an issue, especially those who have more weight to lose. If you see Pakistani or Asian obesity, it is more of on the trunk, right? More on the tummy.
Yeah.
And our females, even males, this obesity is, since it's more on the tummy. When they lose weight from this side, and they're obviously going to have. So the larger weight loss of fat mass you have to lose from the tummy, the more chances of sagging you have. So females, we advise them to get exercise as soon as possible. And in males, even despite exercise, my tummy tuck, which we do, are more in our male patients who are big patients, because somehow the other, their tummy doesn't go back even after the weight loss. I've seen surprisingly female tummy is more elastic, right? Over a period of time, when they do exercise, there is some reduction in it. Their muscle gets strengthened and their sagging gets retracted, maybe in 30 to 40% time. But in male, somehow or the other, sagging does not get retracted as it happens in females. So our majority of patients who are male, like maybe having 170, 180, and they've lost about 50, 60, their sagging is their problem, and we have to fix that sag. But I think with the females, especially those the one who have to lose less pounds, I think sagging should not be an issue.
Excellent. Now, luckily, Professor Neil Hutcher, he is an ex-president of ASMBS and also now president of SRC, that is the accreditation team from US. He's live with us, and Professor, so much thanks. And Professor Farooq Afzal, he is a well-known bariatric surgeon and also leading bariatric surgeon in Pakistan, because I always talk with Professor Neil Hutcher regarding accreditation and center of excellence for any hospital. And Professor Neil Hutcher also, I must inform you, Professor Farooq Afzal is also principal of one of a major medical college, SIMS in Lahore, and soon we will see you in Lahore for our accreditation process. So regarding weight regain, so because you know Roux-en-Y gastric bypass is also the component is restrictive, less hypoabsorptive, and definite. We face weight regain after this surgery. So which percentage of your patients are suffering with weight regain after Roux-en-Y gastric bypass?
Yeah, so 40% of my sleep patients would suffer some sort of weight regain. And there's a less percentage. I think 15 to 20% in our setup, they will have this regain. So as compared to sleep, the incidence is a little bit half, but no operation is immune to regain. I tell you. So there is no ideal operation. Every operation would have regain. There is less incidence of regain with the gastric bypass. But the problem more maybe malabsorptive problems or problem related to macronutrients or micronutrients much more, or internal herniation problem could be more. But this weight regain is still an issue with the gastric bypass. And yes, it has happened to our patients as well. A longer follow-up you have, the longer you come to know, the more you come to know that your patients are having weight regain. As the weight loss happens for the first 1.5 years to 2 years, and then it gets stopped. And it's up to the patient. If they're not changed their habits, if they have not changed their diet plans, if they're not changed their psychology, they're going to get it regain. And especially the Asian food, our food habits, our lifestyles are such that we tend to regain this more as compared to Caucasians. So we need to understand that this we eat for the taste, and this taste, I mean, you know that for this taste we can eat tons of food. Nobody's going to stop us for that.
Definitely. Sometimes, sir, we go standard Roux-en-Y gastric bypass or standard any type of bariatric surgery. So because now we are talking about Roux-en-Y gastric bypass, due to this, I have highlighted Roux-en-Y gastric bypass. Same patient, same ethnicity, about same BMI, same age, but one patient stuck. So then they lost weight at one stage, stuck. So have you any experience to use like GLP1 derivatives for such a patient to lose more weight?
Yeah, for the last 1 year, we are using it, especially in the last 6 months. I have almost 40-50% of my patients who I operated more than 5 years back, and those who are coming to me, I have put almost 40 to 50% of them on these. Initially, this Trulicity and now Ozempic, right? So they are getting the problem with our patient. I was just surprised that we put them on Ozempic and they start nausea and vomiting.
Yeah.
And nausea and vomiting is more a feature in the male patient rather than in the female. So this is something which I have noticed, and I always tell them, especially the male patient, that if you get a first few injection, maybe first or two injection, you will have severe type of nausea, because probably this is one of the mechanism which the drug uses to make you feel less hungry. And if they go through that, this is a wonderful drug. Although they do not take it for longer period of time, and the dose is also very small. We do not have 2.4, which was basically mentioned in the STEP trial. Our injections are maximum 1 milligram. And 1 milligram, if you have to do 1 milligram, use 2 injections, they are too costly for the patient. Mostly they use 1 milligram and maximum for 6 to 8 weeks. But it has a documented effect on one thing. It does produce 5 to 6 kg weight loss. And if it doesn't produce, it doesn't let you gain the weight. And most of the people are happy that, okay, if I take 1 injection weekly, it's going to help me at least not gain the weight, although I'm not losing the weight. So this is psychologically very beneficial for the patient.
Sure, sir. So sometimes, yes, we also face such a situation. And always I prescribe ondansetron along with this Ozempic. So then they, especially for first 2 injection, and they accommodate, then there will be in future no issue. Sir, you have highlighted, so the no, because in your patient after weight regain, there was no need to any surgical intervention. But if patient need to surgical intervention, so what is the best one?
Yeah, so we did distalization in our gastric bypass patients. So we have done distalization, and distalization has definitely some effect on it because their initial BP limb was very small, and we made a larger BP limb, maybe 100 centimeter, and tried to do. So yes, so it does affect. But I would not say that we have operated too much of the gastric bypass patient and converted them. We have operated more of the sleeve patient and converted them into a second revision procedures, but not the gastric bypass. In the gastric bypass, what we operated, we have used distalization of the BP limb.
Yeah, sometimes, sir, there is also gastric pouch size is larger, and also gastrojejunostomy is wider. So in Dubai, because we have this excess endoscopic bariatric, I can ask surgery, and we have excellent endoscopist here. I had some patients, and they resize the pouch with endoscope and also resize that gastrojejunostomy. It was effective. Overall, this was.
No, I agree with that. I agree. But I think such advanced endoscopic services are not available in most of our setups.
Yeah, it's good. So because when we increase this restrictive, and as you have mentioned, so distalization is very effective. But again, there are some issues like especially micronutrient deficiencies, malnutrition. So, but always we must save at least 400 common channel 350.
Yeah, I agree.
That is the most important point. Sir, no, because in this era, I remember, so when I have started bariatric surgery, and during this period, at least I personally, I see many changes. At that time, gastric band, as you have mentioned, so that was the top, and now there is no band, and then run my gastric bypass. And I remember at that time, I was against MGB, and always in different conferences, always talk against MGB, but now my main practice is OAGB. So during this journey, and also you have excellent experience. If I ask, so you have now more than 2 decades, because when you started watching this and also practice in UK, so definitely you are involved with, and also in Saudi. So what is your main concern after Roux-en-Y gastric bypass, after this journey?
Yeah, our main concern is, again, the long-term concerns are to gastric bypass has specific sort of complications. Other than the weight regain, patient, if they are not properly follow up, they will develop either the micronutrient deficiencies or complications related to internal hernias, right? So these patients has to be on a regular follow-up, right? Because people would probably should not think that they have done an operation and now the weight loss will happen and then that's it. They will automatically be cured of the morbid obesity. No. You have to inculcate in their mind that this is a lifelong sort of attachment or relationship with the treating surgeon. You have to keep in touch because your problems can happen at any time. Maybe at 7 years, maybe at 10 years, but the problems can happen anytime. You have to have a regular follow-up. And one of the reasons for follow-up is to monitor for the complication and the monitor for the nutrition, because internal hernias can happen anytime and micronutrient deficiencies can happen anytime.
Sir, excellent. So it's, in my opinion, for our youngsters, it's a great message. So MDT, role of multidisciplinary team, is very important. So this is not only surgeon. So if this lifelong follow-up and MDT is most important, my humble request to all of my youngsters, and that they are just now going to start this surgery. So please, this is our humble request. If you are going to do this, this is not only you do some stapler and stapling and finish. This is not lap chole. This is not just lap hernia. So need lifelong follow-up. Sir, how you predict the future of Roux-en-Y gastric bypass? Is it will be just rescue surgery in future?
Well, with these new drugs and new gadgets, I think there is some jeopardy, but I believe that it probably would remain as a gold standard procedure for at least for the next 25 years. There is a dramatic development of medication. Recently, tirzepatide has come up. We are getting more and more GLP1 agonists and stuff like that. We're trying to understand the mechanism of how hunger happens, how satiety happens, and how the weight loss can be induced. So I think in the next 25 years, pharmacologically, probably will be advancing so much that maybe then surgical intervention would have a lesser role. But at least for the next 25 years, I don't see any diminishing role of gastric bypass till we understand fully the mechanism of how we regain weight and what are the different ways we can lose weight. I think surgical role of gastric bypass, especially the Roux-en-Y gastric bypass, cannot be eliminated.
Sir, as you know, so recently ASMBS also accept one anastomose as gastric bypass. And one anastomose, this is also a little political question, but one anastomose gastric bypass is going to popular all over the world due to less complication and little easier as compared to Roux-en-Y, especially in morbid obese. So are you think in future, so the main hypoabsorptive surgery will be one anastomosis gastric bypass. The role of Roux-en-Y will be just a rescue. So a patient with this GERD after a sleeve gastrectomy, it's okay. Patient with GERD, obese patient, so Roux-en-Y gastric bypass. I don't know. What is your opinion?
I have still my reservation for the OAGB and MGB. Reason why this population is slightly different population. This population would not come for a follow-up. They will only come for follow-up when they have developed the problems. So there is no second thought that it's a very effective procedure. MGB or OAGB is a very effective procedure, and it has associated more metabolic advantages and stuff like that. But considering our own population and considering that most of our obese patients are female patients, development of osteoporosis, development of calcium vitamin D deficiencies, there are more incidents of micronutrient deficiencies with MGB or OAGB. So our own population, their follow-up, their mindset, their lifestyle, right? So for that reason, I think it's a riskier to do an MGB and advocate as the first line procedure. I will still go for the sleeve gastrectomy with the least malabsorptive procedure. And then maybe in my select patients, I will probably choose between the Roux-en-Y gastric and MGB. MGB, yes, it's effective, but the long-term data is not as long as we have for the Roux-en-Y gastric bypass, which is more than 50 years now.
Yeah, because one of the issues are in especially that we are facing in Dubai is restriction after surgery. Now in Dubai, people don't like Roux-en-Y gastric, but that is my personal experience. And always they ask, so I cannot eat so much. But when we do mini bypass and other, in my opinion, this is the also misconception. So they always ask me, we don't like Tagir Masar. Tagir Masar mean gastric bypass. We like that mini, that is the smaller one. So they don't know the smaller one. This mini is more stronger, not smaller.
Yeah, so again, I told you, this is the population. So you have a different population and we have a totally different population. So that's again, they still want to eat, but at the same time, they want to lose weight.
Lose weight, yeah.
So they are a different set. Here, people want to lose weight, but at the same time, people are ignorant, or maybe their resources are not that good enough. So they will not be coming for the follow-up. And they will only come for the follow-up when they have any fracture happened or severe problem happened.
Yeah. Sir, again, luckily still we have live Professor Neil Hatcher is with us. So always I talk with him, and really is sport, because when I received this master surgeon and also surgeon of excellence and also center of excellence in Dubai, so with his sport, we was able to do this, and always I have talked with him for Pakistan. So especially your center, I know that is one of the best center in bariatric surgery. So what's the next step? Have you any plan to such a center of
Yeah,
excellence?
so yeah, absolutely. We have not only planned to do that, but inshallah, in Service Institute of Medical Sciences, we are going to establish a metabolic and bariatric surgery center. We also I've established a training program, so we are going to start it from the university level. So as a principal, inshallah, in the next 1 year, you will see these programs floating. We already, with the help of UHS, we have given our Services Institute a theme. So it's a theme is metabolic diseases, their medical and surgical management. So this is the theme. So Services Hospital is given a theme by the UHS of the metabolic disease management. So in metabolic disease management, we are going to establish this metabolic and bariatric surgery unit. And inshallah, we're going to start this fellowship from the platform of the UHS, and inshallah we'll try to do from the platform of the CPSP as well. Once you get this fellowship, it will have support of the PSMBS, and this is the way I think we can establish center of excellence and training programs so that our future young generations, they get proper training in this very difficult art, but very rewarding art.
Definite, sir. So as you know, so in Pakistan, unfortunately, I can ask. So I remember when I was student at that time, so we were worried about malnutrition, but now we are worried about obesity in our children. Till in our children in adulthood also, and the percentage is varying. That I was just searching in WHO, and overweight 50% people of Pakistan are more than BMI 25. So, and
Absolutely.
also diabetic, 17% people are registered diabetic patient, and the target that we must reach in 2027, already we have reached that. And definitely such a center, such a training center for our youngsters, when population is more than 200 million, and we have more than I think 168 medical colleges. So definite, we need such a training center, and under your supervision, definite this is possible, as I know your leadership abilities, and our best wishes, sir. Sir, regarding, because really so much thanks, and now we are going to close our session. Sir, your message for youngsters who are just now going to start bariatric surgery.
Yeah, I think my message to all the youngsters is first learn the art of surgery. First learn the art of open surgery. You should be very good in open surgery. You should be declared very safe surgeon, laparoscopic surgeon, and then you embark upon the journey of bariatric surgery. It's a sort of a super specialty. If you cannot do a proper lap chole, if you cannot do a proper laparoscopic appendectomy, you should not embark upon the journey of bariatric surgery is little difficult, and especially if you make mistakes initially in the career, then it's going to jeopardize your future reputation plus other. The mistakes can happen in any stage of life, but if you are safe enough in the initial, it will give you confidence, it will develop your reputation, and slowly you can progress in your life. But my advice is to please focus on acquiring knowledge and particularly skills and attitude that will enable you to become safe laparoscopic surgeon first, and then the bariatric surgeon.
Sir, so much thanks. Really, this no doubt this was one of my best interview session. I know you are so much busy, and again, really, always you are sportive, no doubt. Always you are encouraging. Always you are sportive, and I must mention, in Pakistan, you introduced me in 2016. So it was the first time that I was in Pakistan, and so literally I have started to sharing knowledge. Sir, again, so much thanks. And in future also, we need your support. We need your guidance.
No, I really want to thank you and I want to appreciate all your efforts. And Alhamdulillah, now I feel very much relaxed because I know that my job is handed over to my other brothers and they are doing it better than me. I wish you Godspeed in everything and please keep it up. This nation is full of talent. These boys and girls are full of talents. And if we just give them some encouragement and focus and support, they are the world beaters. They are the best in the world. So very well done. Thank you very much for giving me the opportunity.
Sir, so much thanks. So much thanks, really. And we will continue this series. And next week, we will be with Professor Ramon from Barcelona. And also in June, we will have a sum-up session. And from July, we will start metabolic surgeries in low BMI. That will be also for 6 months. And every Tuesday, 10 p.m. Dubai time, we will continue this series of interviews. And in 2023, so we will continue with redo surgeries. We need your support, and these all sessions, my viewers, is due to your support. And if you have any question from Professor, you can ask in comments and ask directly. Sir, again, so much thanks and have a nice time.
Thank you. Thank you very much. Thank you all the audiences and thank you very much.
So much thanks.